Good evening, everyone. So we are going to start our program. So today our BUS symposium is on the topic of CA prostate. And you know that it is a very interesting topic. Lot of discussion, but still there is many confusion. So today our speakers are Saptarshi Mukherjee, Dr. Tapas Kumar Maji, Dr. R.K. Gopalakrishnan, Dr. Abhay Kumar, Dr. Amitabh Rai, and Dr. Rajendra Rai. So we are going to start our program. May I invite our president, sir, Dr. Malay Kumar Bera, sir, to kindly come to the dais and to open our symposium.
Good evening to senior teachers and our juniors. Today, our topic of this CME program is on management of the carcinoma prostate. You have already heard from Dr. Chaudhary that the name of the speakers. We shall not waste our valuable time. May we start the CME program now?
Okay. Thank you, sir. So we are going to start a program. It is only on the management of CA prostate. So our first speaker, Dr. Saptarshi Mukherjee, who is HOD Department of Urology at ESI PGIMR Joka and concerned urologist at Kolkata Kidney Institute. Dr. Saptarshi, please.
Good evening to all my seniors and dear colleagues. Actually, it was quite a daunting task when I was asked to present this vast topic, and that too within a 10-minute frame. But I would try to incorporate the most important salient points over here. So please bear with me if I go beyond the time frame by a few minutes. So regarding the overview, we all know fighting a cancer is nothing less than a war. And as Lord Krishna have told, two things we should be aware of in a battle. That is, what are the weapons that we are provided with and where exactly to use those weapons. So I will try to answer these two questions in this presentation. That is, what are the weapons and where exactly to use them. So the weapons at our hand, as far as CA prostate is concerned, is surgery, radiation, ADT, chemo, conservative, and the combination of them. So CA prostate has been quite a common disease, and the major concern that have arisen out of this is over-diagnosis with over-treatment. And most of the treatment modalities of CA prostate are associated with gross alterations of the quality of life of the patients. From this area have come up the concept of deferred treatment. We have two options over here. One being the watchful waiting and the other one being the active surveillance. But both of them vary in their intents grossly. The intent for watchful waiting is palliative and typically applied for patients with less than 10 years of life expectancy and practically is applicable for all the stages of the disease. Whereas in active surveillance, the intent is essentially curative. Here our aim is to reduce the treatment-related toxicity, but not at the cost of survival. So mostly applicable for low-risk patients. Coming to the local forms of treatment, here we have surgery in the form of radical prostatectomy, which can be applied as a solo treatment or also as a part of multimodal approach. Radiation therapies in the form of IMRT or volumetric arc-mediated radiation under image guidance has become the standard of care in this era. Hormonal therapy intends at reducing the testicular androgen levels. This can be achieved either surgically through orchiectomy or through the use of drugs like LHRH analogs, antagonists or anti-androgens. Over the last few decades, as we have gone much more clearer with the concept of CRPC, has come up the new androgen receptor pathway inhibitors like the abiraterone acetates or the enzalutamide. There are many newer drugs like the non-hormonal, non-cytotoxic drug treatments like the PARP inhibitors or the immune checkpoint inhibitors. Their role is still limited but have been proven to be useful, especially in patients with documented germline mutations. Radiopharmaceutical therapies like the use of radioactive ions directly to local targeted areas. Whole gland therapies like the cryotherapy or high intensity focused ultrasound, unfortunately their role is still not very clear outside the clinical trials, be whatever be the stage of the disease. Now we know what the options we have. Now let us see how we can apply these weapons and options respective to the different stages of the disease. If we consider this table becomes of paramount importance. That is the EAU risk table, where they have stratified the patients into the low, intermediate and the high risk variety, depending upon the PSA level, the Gleason grade and the clinical T and clinical end disease. So let's start with the low risk disease. Low risk disease, the major problem in this group of patients has been overtreatment and hence the attendant complications with it. So there has been a paradigm shift in the management of these low risk patients. In this recent EAU guideline, they have mentioned that active surveillance should be regarded as the first choice of treatment in this group of patients. Though the strict inclusion criteria is still obscure, but the consensus is that the ISUB grade 1 tumors, the clinical T1C, T2A tumors, and the PSA levels of less than 10 nanograms per ml should be the inclusion criteria. So how can we actually approach and select these patients for AS? Important is patients with intraductal histology on biopsy should be excluded from active surveillance and do perform an MR before a confirmatory biopsy if no MRI has been performed before this initial biopsy. Again, if a patient has had upfront MRI followed by systemic and targeted biopsies, there is no need for confirmatory biopsies. A bit confusing, so just to make it simple, a patient has come to us with a biopsy report, a prior biopsy. We will go for an MR followed by a confirmatory biopsy. What is that? A systematic biopsy along with a MR targeted biopsy. Only then, based on that report, we can stratify the patient and whether the patient is suitable for active surveillance or not. And if the patient has got an upfront MR with systematic and targeted biopsy, no further biopsy is required. Surgery and radiotherapy. These are merely the reserve bench players as far as this low risk group is concerned. Only and only if the patient is unwilling or is quite apprehensive of harboring the cancer, these therapies can be offered to him. ADT as monotherapy. No evidence supporting the use of ADT in this asymptomatic men with low risk disease. Just a bit talk on the follow-up. It is to be done based on the DRE, the PSA, and a repeat biopsy to be done every 2 to 3 years. A breakthrough biopsy is indicated along with an MR only if there is a PSA rise. And reclassification is to be done only and only on biopsy finding, not on MR changes or on a PSA rise. That is, if it comes to more than 3 positive cores or more than 50 core positivity. Now comes the intermediate risk group. From this stage onwards, we are provided with an array of choices and the confusion arises. So what's the guideline does say? Offer active surveillance to highly selected group of patients. Who are those patients? Especially the ISUB grade group 2 disease or patients with low biopsy extent, that is less than or equal to 3 positive cores with less than 50% core positivity and also low disease extent on the imaging. Or just to make it simple, it should be only a single positive point on the intermediate risk criteria. That is, be it PSA, be it the clinical T, or be it the glycine. Radical prostatectomy can be offered and should be offered with a life expectancy of more than 10 years in these patients. EPLND, as per the guidelines this year, is not mandatory in all patients. To be done only on those patients with a predicted risk of lymph node involvement. So, again to summarize, active surveillance can be a consideration in low volume ISOP2 disease or patients with a single element of intermediate risk disease. But the patients must be counseled about the higher risk of progression. Radical prostatectomy, the most and the very large 2 RCTs have typically shown a decreased risk of death and progression in this group, and EPLND to be considered only if the estimated risk exceeds 5%. Radiation therapy, if contemplated, should be carried out along with a concomitant short-term ADT of around 4 to 6 months. Again, ADT as a monotherapy is not a standard option. Coming to the high-risk variety, which is another localized one. Radical prostatectomy, again, can be offered as a part of multimodal treatment, especially in patients with low tumor volume. Just unlike the intermediate risk variety, EPLND should be considered in all the cases. There is no role of any new adjuvant therapy, but the patients to be counseled about the requirement of adjuvant radiation or ADT in these patients. And presence of a paroperative node should not make the surgeon abandon the procedure. So, as far as the radiation is concerned, if radiation is to be contemplated, offer a long-term ADT of around 2 to 3 years in these patients. And if it's an unfavorable group, a brachy boost can be considered if the patient is having minimal LUTs. It is from this disease the concept of ADT monotherapy first arises, and to be considered only and only in those patients who are actually unwilling and not willing to accept any form of local treatment, and in addition to that is having some poor PSA kinetics or a poorly differentiated tumor. Coming to the locally advanced disease form, radical prostatectomy is definitely an option here also, but again as a part of multimodal treatment, and just like in the high risk localized variety, perform EPLND in all the cases. Coming to the radiation part, here it becomes a bit catchy. Here also we should offer a long-term ADT in conjunction with radiation in a CN0 patient. But if there are more than 2 risk factors, that is either it's a T3, T4 or a high glycine grade or a high PSA, that is more than 40 nanograms per ml, that is any 2 if it's positive, consider addition of 2 year of abiraterone acetate in this group. So in a CN1 patient, consider on air along with the abiraterone acetate and the concurrent ADT, include the pelvis also in the radiation field along with the prostate. So local and systemic treatment, a combination of both has been found to be of optimal outcome in locally advanced disease, though prospective data are still awaiting. RP, as I've mentioned, can be considered as a part of multimodal treatment. Radiation, either along with a long-term ADT, or if more than 2 risk factors are there, addition of abiraterone. And in CN1M0 patients, consideration of a local treatment along with long-term ADT. In radiation, it is to be, the pelvis should be included. Coming to the metastatic CA prostate, the first thing that should go into the prescription is offering ADT to this patient, be it in the form of LHRH antagonists or a combination of LHRH agonists and anti-androgens. But the interesting point here is, if the patient is having a good performance status with no specific contraindications, that particular patient, especially with a synchronous M1 disease, should be offered a combination therapy in the form of ADT and other systemic therapies like abiraterone acetate or even enzalutamide. In fact, what they've mentioned is offer docetaxel to patients who are fit for actually chemotherapy, but that too in combination with ADT plus abiraterone. Do we consider local treatment in an M1 disease? Here the recent US-based Charted trial and the UK-based Stampede trials have come into vogue. They have classified the patients into a low-volume metastatic disease and a high-volume metastatic disease. So, if it's a low-volume metastatic disease, local treatment should be considered in the form of a non-curative radiation therapy. Can be given along with the other systemic forms of therapy and ADT. But local treatment should not be in the form of surgery. That is, do not offer ADT combined with surgery outside clinical trials. Coming to CRPC, here the choice will depend upon the performance status of the patient, the symptoms the patient is actually suffering from, and the most important, which treatment the patient was already on. So it's just like being a good captain on the field. Just keep on shuffling your strike bowlers. If the patient had 1 or 2 cycles of chemotherapy, offer abiraterone or enzalutamide. If the patient was already on abiraterone and enzalutamide, offer a chemotherapy. And if the patient has progressed on docetaxel and is still fit, offer life-prolonging agent in the form of cabazitaxel. 2 interesting points. If the patient is having a particular germline mutation to be positive, PARP inhibitors can be offered to these patients. And recently, FDA has approved a radiopharmaceutical agent, that is the 177 isotype of lutetium in PSMA expressing metastatic CRPC cases. Now, just to sum up the entire thing, a patient with a known case of CA prostate, a non-metastatic patient, have come to you. The first thing that we should look for is the performance status of the patient, the life expectancy. If the life expectancy is 10 years, whatever be the risk stage, whatever be the stage of the disease, watchful waiting comes into view. If the patient is a good candidate for treatment, then we go for risk stratification. That is, whether it's a low risk disease or whether this is a favorable group of intermediate risk disease. If that, active surveillance can be an option. If not, in a unfavorable group of intermediate risk disease, we can have loads of options. Either radical prostatectomy with or without EPLND, not necessary in all the cases. Or if radiation therapy is to be contemplated, a short course ADT of 2 to 3 months should be considered. Coming to the high risk, localized and locally advanced disease. Similarly, radical prostatectomy, again an option, but here the concurrent ADT treatment should be a long-term one of around 2 to 3 years. Moreover, if it's associated with some high-risk factors like what I have mentioned, it's a T3, T4 disease or a Gleason grade of more than equal to 8 or a very high PSA value of more than 40 nanograms, consider admission or administration of abiraterone acetate of 2 years. And if it's a CN1 disease, the radiation field should include the pelvis also. Similarly, the flowchart for metastatic CA prostate. The first thing is continue the castration and then assess the life expectancy of the patient. If the patient is having not a good life expectancy, not a good performance status, no upfront combination therapy is to be considered. But if the patient is having quite a good performance status, then combination therapy, that is a double combination therapy in the form of ADT and abiraterone acetate or enzalutamide should be considered. The next step is stratify the patient whether it's a low volume metastatic disease or a high volume as per the charted trial. If it's a low volume disease, consider local treatment in the form of radiation to the prostatic bed. And if it's a high volume, no role of any local treatment. But irrespective of the volume of the disease, check whether the patient is eligible for docetaxel. And if the patient is eligible for docetaxel, again consider the triple combination. That is docetaxel, ADT with another systemic therapy. So we do see that we have a lot of buffet of choices in these patients. It's not about thinking which one is better over the other. It's just that we have to fight like a team. Only then perhaps we can cut the ugly head of CA prostate. Thank you. I would request the house, if I'm not too much overboard, I have kept just few 4 or 5 slides to discuss few more issues. If it's permitted, I can show the 4 or 5 slides. Okay.
See, before that, if there is any questions from the senior members, so you can put your slides accordingly. So, Karmakar sir, have you any specific question? Sir, Beda sir? Anyone has any specific question so that you can put the slide accordingly. I have one question. What do you mean by upfront abiraterone and upfront docetaxel?
Upfront docetaxel that I have mentioned in a metastatic, it's important, it's a synchronous M1 disease. Upfront mean you start at that moment only. You mention the ADT in the prescription and then only at the same sitting discuss the combination therapy, provided the patient is healthy and is in a receptive state. So there is a big geriatric scale that have been mentioned in the UAE guidelines right now, depending upon this. So if the patient is really fit for that, an upfront combination therapy should be discussed with the patient.
Tell us a little bit more about the triple combination therapy which is now being advertised.
So the triple combination therapy, if I can go back to the slide, what they have mentioned, first of all, as I mentioned in the flowchart, the patient is an M1 disease, synchronous M1. What they have mentioned mostly about synchronous metastatic disease, and the patient is a good performance status. We start ADT as we used to do. Along with that, start the new androgen binding pathway inhibitors like the abiraterone or enzalutamide. If the patient is tolerating well, so triple combination therapy. If the patient again is a fit one, docetaxel can be started in the normal dosage regimes only. That is around 75 milligram per meter square every 3 weeks, and to be followed up on that.
Actually, the first minimal invasive surgery regarding this. Nowadays, the cryoablation, ICU, something.
So I actually mentioned just in the front, what I mentioned that these whole gland therapies, what they have mentioned, they are still restricted within the clinical trials. And because sir, it was an overview, so I could not actually incorporate the details of that. So, but sir, I wanted to discuss few important issues regarding for the CA prostate. That is, yes, sir.
Mike.
As you mentioned in the metastatic disease about the triple combination. So before actually the previous mode of treatment was you put your cards one by one.
Yes.
Isn't it? You see the progression, whether there is a PSA rise or imaging abnormality, and then you decide to go for second or third drug. So do I understand that this is not done anymore? That you give all the three at the same time, regardless of money, that entails a lot of toxicity also.
Sir, as per this, what they have mentioned, few prospective data are awaiting. There is a basic pathobiological difference between a synchronous M1 disease and a metachronous M1 disease. So, in a synchronous M1 disease, where the patient is actually presenting to us with metastasis, have been found to have a very poor progression. These are the patients with quite high PSA values and often with high volume disease as per the charted trial. So, rather than picking out the cards one by one, going all the guns together, perhaps but still, sir, lots of prospective data are awaiting. So this is a paradigm shift in this year of guideline that they have mentioned about the triple regimen.
Very nice presentation, sir. I want to ask, sir, one question is, if the patient is of metastatic CA prostate, sir, but patient is dependent on catheter, so is there any role of channel TURP or anything like that?
This we have been answering from many long things. A patient who have been on catheterization, so the components for which the retention have occurred, that is important. It can be due to the benign component of the prostate. It can be also due to the malignant component of the prostate. So a combination therapy of alpha blockers as well as androgen deprivation therapy is to be contemplated, what we used to do. And then after around 4 to 6 weeks, so we can go for a trial provided there is no evidence of any upper tract deterioration or any obstructive nephropathy. And if the patient fails with proper pros and cons, explaining the patient about incontinence and everything, a channel TURP can be contemplated, I think. The seniors will definitely highlight upon the point, sir.
Actually, after conservative management, more than 50% of the cases we see that if you remove the catheter, they worsen. Because the channel TURP is not the permanent solution. After channel TURP, few months after that, you will get again obstruction. Patient will be fed up. After undergoing this operation, his expectation was more. So usually we avoid channel TURP. When there is failure of all the processes, then you go on channel TURP. But proper counseling should be done.
As we have told that because of the recent trial, whenever you are mentioning the term metastatic, another question comes whether it's a low volume metastatic disease or a high volume metastatic disease. So if it's a low volume metastatic disease, you are actually considering a radiation therapy. So in that case, even if the patient is on catheter, the question of TURP amidst the radiation becomes quite difficult, I think. So just the few slides. I have not mentioned about the adjuvant treatment. So radical prostatectomy is done, but the question comes to be a PN0. We do not prescribe any adjuvant ADT for these patients, but in radical prostatectomy with a PN0 patient, we must scrutinize the biopsy report a bit more, whether there is any evidence of T3 plus disease or any positive surgical margins. What is the ESUP grade? So if these poor prognostic markers are present, we should offer an adjuvant IMRT or VMAT in these patients. In PN1 disease, it's quite clear. We have to offer some sort of adjuvant therapies like adjuvant ADT or a combination of adjuvant ADT with radiation. Only in very few selected patients where the number of retrieved nodes is less than or equal to 2 with a PSA of less than 0.1 nanograms per ml, we can consider observation, explaining the patient that he should be on a strict follow-up because a high risk of progression is already there. Post-RP issues. There is an issue which we call as a persistent PSA. We should not confuse it with a PSA rise after biochemical recognition. It's a persistent PSA. What is this? We have done the radical prostatectomy. Within 4 to 8 weeks, it should come down below the castrate level. With the introduction of the much more sensitive PSA markers now, it's considered less than 0.1 nanograms per ml, but it has failed to do so. What to do in those situations? So offer a PSMA PET CT scan in those patients. And if there is no evidence of metastatic disease, offer salvage radiation with additional hormone therapy. I was talking about the rising PSA. This is a different issue. Here again, in the AUA guideline, the patients with rising PSA after radical prostatectomy have been divided into 2 groups. The EAU low risk group and the EAU high risk group, depending upon the PSA doubling time and the pathological grade. So it's quite simply, they have mentioned that patients monitoring should be the rule of thumb for low risk patients, strict monitoring. With 2 consecutive PSA rises, consider salvage radiation and ADT. Whereas in high-risk patients, directly go for salvage radiation and ADT. Bone protection, we all know, do offer bone protective agents with monitoring of serum calcium, either the patients on denosumab or bisphosphonates. And last but not the least, one we do not talk about too much about the non-metastatic castrate-resistant disease. Offer apalutamide or the other agents to patients of M0 CRPC only if there is a high risk of developing metastasis to be guided by PSA kinetics, namely PSA DT, which should be less than 10 months. And in those cases, it have been shown to prolong the survival. Thank you.
Thank you, Saptarshi, for a very nice presentation.